To smooth anesthesia induction, be sure all of the required supplies are functional and close at hand. Supplies for anesthesia induction include an anesthesia machine, an endotracheal tube of a size appropriate for the patient, a syringe to inflate the endotracheal tube cuff, an intravenous induction drug, a laryngoscope, roll gauze or some other suitable material for securing the endotracheal tube once it is in place in the patient, fluids, lubrication for the eyes, and monitoring equipment. Also make sure you have an oxygen supply for your machine and that the anesthetic vaporizer is full. First of all, connect your machine to an oxygen source and the waste gas scavenger system. After connecting to an oxygen source, make sure that oxygen will flow into the system. If there is an oxygen tank on your anesthesia machine, make sure the tank pressure is at least 500 psi. If the oxygen tank pressure is less than 500 psi, replace it with a fully charged tank. The anesthesia machine and breathing circuit must be checked for leaks before connecting to a patient. Close the pop-off valve and occlude the Y-piece using your thumb. Turn on the oxygen flow and wait until the circuit pressure reaches 40 centimeters of water. Next, turn off the oxygen flow and observe the pressure gauge on the circuit. If the pressure in the circuit cannot be maintained over 10 seconds, check for leaks in the circuit. The health of every patient undergoing anesthesia should be evaluated. The cardiovascular and respiratory systems are especially important because of their role in providing oxygen to tissues and their participation in acid-base homeostasis. Evaluation of the patient's heart rate and rhythm, lung sounds, pulse quality, and capillary refill time are examples of cursory physical examination elements. Because premedication may alter a patient's physical status, carefully observe the patient again just prior to anesthesia induction. Place the patient on an elevated work surface and place a catheter in the cephalic vein using proper technique. Before administering an intravenous induction drug, make sure the catheter is in the vein. You can visually inspect while injecting a small amount of fluid to check for accumulation around the vein. Swelling associated with the fluid injection indicates that the catheter is not in the vein and requires replacement. Another method of assessing correct intravenous catheter placement involves using an open administration set and gravity. Open the roller valve of the fluid administration set and lower the fluid bag below the level of the patient's heart. Blood will flow back into the fluid administration set if the catheter is properly placed in the vein. Insert the syringe needle through the injection port of the fluid administration set and pinch the fluid line to occlude it. The administration rate of the induction agent varies depending on the drug being used and the health of the patient. Propofol injection should proceed slowly because rapid administration can cause apnea and significant hypotension. Check anesthetic depth frequently as induction proceeds. Discontinue administering the induction drug once the patient loses the palpebral reflex and you can easily open the jaw. Leave the syringe in the administration port in case more drug is required. Intubation is the next step. An assistant can hold the mouth open by grasping around the upper canine teeth with one hand and pulling the tongue out between the lower canine teeth with the other hand. The patient's head should be oriented straight toward the anesthetist performing the intubation. Clear visualization of the arytenoid cartilage and vocal cords is the key to correct intubation. Place the end of the laryngoscope blade on the base of the tongue and gently push down to bring the epiglottis toward you. Reposition the laryngoscope, the patient, your hands, or your assistant's hands if you are not able to clearly see the glottis. The endotracheal tube should go between the arytenoids and vocal cords. If the epiglottis is entrapped by the soft palate or is closed over the larynx, do not try to push the tube into the trachea. Use the endotracheal tube or laryngoscope to free or move the epiglottis before attempting intubation. Once the tube is through the larynx, gently push the tube into the trachea. Proper placement of the endotracheal tube is confirmed by palpation of the neck. The esophagus is soft and usually hard to palpate. If the tube is in the esophagus, two firm tubes are palpable in the neck area, one being the trachea and the other being the endotracheal tube in the esophagus. If you feel two tubes, remove the endotracheal tube and start over again. Once the endotracheal tube is properly positioned in the trachea, turn on the oxygen and connect the breathing circuit to the tube. Avoid placing the endotracheal tube into a main stem bronchus by ensuring that the end of the tube is proximal to the thoracic inlet. Place one hand around the thoracic inlet and gently manipulate the tube. Move the tube to the proper position while palpating the trachea. Secure the endotracheal tube using roll gauze or other material tied onto the tube and around the maxilla or around the patient's head. Close the pop-off valve on the anesthetic machine and squeeze the reservoir bag to pressurize the anesthetic circuit up to 20 centimeters of water. Listen at the patient's mouth for the sound of gas escaping around the endotracheal tube cuff. If you hear a leak, place a small amount of air in the cuff and pressurize the system again. Continue this process until the system will just hold 20 centimeters of water pressure without leaking. Open the pop-off valve on the anesthetic machine and allow the patient to breathe spontaneously or assist ventilation as needed. Palpate the femoral pulse to confirm that the patient is alive, and then turn on the vaporizer and adjust the vaporizer based on the patient's anesthetic depth. Open the fluid administration set and adjust the fluid rate based on the patient's weight. Place eye lubrication in both eyes. Place a pulse oximeter probe on the patient's tongue. A pulse oximeter indicates the percent saturation of hemoglobin in arterial blood. This number should always be more than 95%. Next is blood pressure monitoring. Select an appropriate cuff based on the patient's size. There is a size indicator on the inside surface of the cuff. The single line should fit within the indicated circumference range. After placing a cuff on the distal limb, turn on the monitor to begin non-invasive blood pressure assessment. The mean arterial pressure should be greater than 60 millimeters of mercury during anesthesia. By following the procedures outlined in this video presentation, you will be able to perform anesthetic induction and patient monitor placement smoothly and efficiently.